Good morning. Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live from the Dolph Simons Family Studio. We're back with you this morning. I am joined on my right by Hawkeye, who returns again, faithful partner, and on the left by David Wild, Vice President of Business Intelligence Performance Improvement here at KU. We want to go through some really important information for you regarding the statistics here that have happened within our health system that I think help exemplify things that are probably going on around the country. But first, Hawkeye, let's talk about our numbers, and then we're going to segue to an important moment.
Yeah, so the last couple of days we've been in the low 30s. We have 32 active patients today. The real concerning thing about our active patients, though, we have 9 in the ICU, but 7 on the ventilator. So that is almost 80% of our people in the ICU on the ventilator, and that's a really concerning thing.
In the medical ICU, to say.
In the medical ICU, yep. We've had 10, recently we've had 10 in the ICU, but only one of those was on the ventilator. So when you get up to having higher percentage on the ventilator, that's pretty concerning. We still also have 26 people in the hospital who are in that recovering status as well. And out in Hays, it seems like they have had some discharge. They have 12 people with active infections, and they have 1 that is recovering as well. So that's good.
So we've said on this program before that coronavirus is not a superhero. It does not jump through walls. It does not jump over tall buildings. It does not have X-ray visions. It also doesn't care. It doesn't care who you are. It doesn't care what political party you're in. It doesn't care about state lines. It doesn't care about how much money you make. It doesn't care if you're the president of the United States. So today the news of that the president and his wife testing positive for coronavirus. Let's talk about that for just a moment. But I do think it exemplifies that important principle. Coronavirus does not care. We care, right? We care. People care. We care for each other. But coronavirus doesn't care. And it can infect anybody at any time. So he and Melania, President Trump and Melania have tested positive for the virus. Therapies that they would receive, we could speculate about. We don't know.
Right.
But certainly there are, therapies that have come further along with remdesivir and things like that. There are some of these drugs that are in trial, like the monoclonal antibodies that are not really available to the public except through trials. We don't know what medications he may or may not have had, Dana.
Yeah, absolutely. We do get this question a little bit. Again, there is no good algorithm or there's no treatment plan for somebody who has the disease and is not in the hospital. Typically for remdesivir, which is the antiviral that we use, it is in hospitalized patients. Typically for people who get convalescent plasma, it's in hospitalized patients. Also for people who are getting anticoagulation, as well as steroids in general, you are in the hospital to get those. So, hopefully he stays well. Certainly it sounds like he's well right now. I would imagine, and again, it's speculation, but having the best resources at hand, you could probably start to get those things as an outpatient. He may or may not be getting those things, such as remdesivir, such as plasma. And we also know, and we're pretty confident, that the timing of these drugs is very important. So earlier on in the infection is probably going to have a higher probability of having a better effect, a favorable effect, to stop that course that is later with all the inflammation and all the immune system dysregulation as well.
David, we know that the president is tested almost daily. So talk to us a little bit about it. I mean, you get tested at one point and you're negative. You're tested later in the day and you're positive. Of course, that's what we would expect to have happen.
Yeah, so we've sort of shared this message from the beginning that a negative test is really only valuable for the moment in time the test was taken. And it sounds like part of the story here is that maybe one of the White House aides, the staffers who they believe is the source of exposure for the president, had actually tested negative earlier in the day, maybe on Wednesday this week, and then by the evening started having symptoms, tested again in the evening on the same day, and then was positive or something along those lines. And I think that's a very common situation. It's the reason that we say you can't test out of quarantine, that a negative test on day 7 means nothing on day 8 if you start having symptoms. And so I think that story probably makes sense. It's very likely that was something along those lines, was sort of really what happened here. And it's a good reminder to all of us.
Yeah, and given that he tested, if in fact it is what we are being reported is true, he is tested daily, then the debate was on one day, and he tested negative the next day, and then negative, then positive. So hopefully at the time of the debate, Biden was not exposed because I'm going to guess everybody got tested right before the debate. So
Yeah.
at least if they play it like the NFL does.
Yeah, and I thought I heard that they probably were. The other thing that you had pointed out about the test is if she had symptoms or if the staffer had symptoms on Wednesday, we know that you are probably very infectious 1 to 2 days prior to those symptoms. So that would put you in the Tuesday to Monday time period as well for being
that
very
staffer.
infectious.
Yeah.
Yes.
Yeah. And so if the president's test was Thursday night, it's very possible that Wednesday night or even into Tuesday night there was some risk. But the sort of dynamics of what the stage looked like, how far people were apart, who
Right.
had what contact, it's really hard to know.
And as soon as you start shedding virus, you should be testing positive. So if they got tested before the debate, you should have been negative. And so that, I mean, theoretically, once you shed, you're positive. So we'll see how this plays out, and our thoughts and prayers, of course, with the president and his wife, and with everyone who is struck by this difficult virus. And yeah, that's right. What me worry. This is a great picture. You can put that back. What me worry. Yeah, that's my young me. And trust me, as a teenager, I was always worried. But I do look a little like the mad comic book character. Those who know me know that that's a pretty good resemblance, and in many ways I probably resemble it more than just physically. So thanks to our team for helping me with that picture.
Yeah.
So we do have a lot of important questions today. We wanted to take that one head on. Before we go further, let's first, Jill, see if there are questions from media.
Hi, good morning. It's Lindsay from 41.
Hi, Lizzie.
We just wanted to ask, when you have a very public case like this with someone who we now know publicly where they've been, maybe even know a little more about the spread, do we expect to learn more about how the virus spreads, or is it too isolated an incident to change our knowledge or confirm it or anything like that?
Yeah, I don't think we're going to learn more about how the virus spreads from the president's becoming positive, because all you've heard us say on this program before, the pillars of infection control follow you wherever you go. If you follow those pillars, you can really work to stay safe. And the most important pillar of that pillars are to wear a mask and to be socially distanced. So what we are learning is, again, coronavirus doesn't care. It doesn't care whether you're a Republican or a Democrat. It doesn't care whether you live in Kansas or Missouri or anywhere else. It doesn't care how much money you make. What happens is coronavirus is a virus, and it's going to spread just like influenza or the regular coronavirus or rhinovirus. And what we're seeing is that the pattern for coronavirus holds true just as we would have predicted it did. And eventually, if you don't wear a mask and you don't socially distance, this is when you get into trouble. So I don't think, and I look at my team, I don't think we're going to learn anything new from this other than maybe a message that we are all vulnerable and susceptible to this virus that doesn't care.
Yeah, and I would agree with that. I think it's interesting, though. I think it's interesting to do the contact tracing and learn about all of these types of things. And it's interesting because it's an individual level. These aren't, in general, these aren't just numbers of infections and deaths. These are individual people. And when you do these contact tracing and these public, these reports of, say, the people in the choir practice, or up in the wedding in Maine with all the spread and things of that. They are very interesting individual stories, and I think that will be the very positive point to bring out of this. Just as you said, anybody is susceptible to this. And so, really bringing it down to that individual level, because all of these cases, all of these deaths, all of these sick people, they aren't just numbers, they are individual people. And so for that point, it's going to be very interesting.
It may make it feel real to people. And so,
Yep.
again, the learning from it may be how real it can be for all of us, David.
Yeah.
Yeah, I think that's exactly it. I think that probably the most benefit we will see in how we use what information does come out of this will not be in new learnings of how disease is transmitted, but instead having those individual stories and understanding of how a very public figure in a team that supports that person interacts with others outside the office. Those things, I think, will help us share a message. I don't expect that we'll learn a lot about transmission dynamics from this.
I don't think we will either. And we've been saying coronavirus is not a superhero. The reality is neither are you, right? None of us are. And we're all susceptible. You got to listen to this guy right here because he tells you the truth. And I think that we all make mistakes. We may not always be right on coronavirus, and we've said it before. We're building an airplane while we fly it, and sometimes the parts don't fit, and sometimes we're wrong about what part we're trying to put together. But it doesn't mean we aren't trying to tell the truth, and that's what we've dedicated ourselves to on this program, is just trying to tell you the truth so you can use your best judgment about how that fits into your own life. And again, we come back to the base message we've had since day one. If you follow the pillars of infection control, it really helps keep you safe. And when you violate those rules on a regular basis, the coronavirus, you're just opening yourself up and you're making yourself more vulnerable. And that's what this shows us. Coronavirus is not a superhero. It doesn't care. You're not a superhero, not really, but you do care. And that's the difference. And if you care enough, you can help stay safe.
We do have a couple of questions that are related to the president.
Please.
One of them is, Michael wants to know, because of his age and his weight, is it a given that he will get very sick?
It is not a given that he'll get very sick. In fact, even at the age of 80, what are the odds? 1 in 5, and then this is assuming he didn't have remdesivir and one of the monoclonal antibodies already, et cetera. But I think it's 1 in 5 people over 80 who have coronavirus could come into the hospital. Is that right?
That sounds right. I'm not sure that we really.
I don't think we. I know. I did this math in my head one day, so that's a very dangerous place to be. That is, having me do math in my head. Right. Others will tell you that.
More dangerous than a high school picture.
Yeah, that's a junior high school picture. Okay. Please get my timeline right.
Yeah, I think clearly, right, the rule of sort of probability that we look at when you say what is the risk or what are the odds is maybe a better way to say it of someone of a specific population, whether that be age or comorbid conditions, ending up really sick. That's not a guarantee, even if it was a higher probability, 50, 60, 70% chance that someone with in that population got really sick. It doesn't mean that anyone is guaranteed. So. That plus all of the potential treatment options we've outlined, I think, probably make it likely that we won't see truly, really severe disease in the case of the president. But that's not a guarantee either. So.
Yeah.
But he is at higher risk because of his weight and because of his age. Those are just medical facts. We're not trying to be negative about him at all. I'm just trying to say, if you're over 80, or 70, sorry, and if you are overweight, those do put you in a higher risk category. Regardless, again, what you want to believe, what your political party is, that's just the epidemiology of this.
Right, and I think the important distinction there, right, there are two risks we're talking about here.
Please.
There's a risk of getting COVID, right, from someone else because of the way that you interact with others, whether you wear a mask or not, right? Those things are independent of age and of comorbid conditions. The risk of transmission, of getting the disease, is really based on how you act, what you do, how you keep yourself safe. Separate from that, there's a risk of severe disease if you have the infection, if you have the virus. And so in this case now, we're not talking about age or comorbid conditions don't make you more likely to get the disease, but they do make it more likely that you'll have a severe case when or if you get it. And that's really the conversation here.
Yeah.
Yeah, really nothing to add. And I think we've seen recently the Missouri governor tested positive, and as far as I know, I think everything has gone well with that. So, just nothing to add. Exactly what you're saying. Just risk and other comorbidities age and other comorbidities put you at higher risk of having hospitalization and severe outcomes. It doesn't mean it's going to happen. So.
Yeah, and so I think that the odds are that the president and the first lady will be okay.
I think so.
And I think that we'll pray for Godspeed and for grace around that.
Yeah, the questions are flooding in, and they're good clarifying questions. I think one of them is for Dr. Hawkinson. They said, on Wednesday, you were talking about you don't have to worry about contacts of contacts. Mm-hmm. And if Hope Hicks learned she was positive, she was contagious, and likely was the vector to the president, now we're worried about Biden, who is, he says, socially distanced and a contact of a contact of a contact.
Yeah.
Can you just speak to that?
Let's talk a little bit about that. Yeah. And also just to say, before we all say that Hope Hicks was the vector, the two of them could have had a common vector, and it may not have been Hope, because they both got sick in which you get concerned about, because both the president and his wife are positive, is that there will be multiple close contacts around that are positive. And I love football. We've seen the Tennessee Titans be negative on one day, be negative in the time of the game, and then 2 days later they're positive. Well, so far the Vikings haven't been positive, but it's early. And we'll have to wait and see how that plays out. And what we're seeing is that more people on the Titans are becoming positive. What it means is that you can be negative in the morning, as you said earlier, positive in the afternoon, and that's when you're starting to shed and spread the virus.
Yeah, I think that there's nothing I have to add to that to come to that question of, well, what about contacts of contacts of contacts? So at this point, the concern maybe about Biden isn't that Biden was a contact of a contact, right? And that the initial source, whether that be an aide or someone else, is any risk to Biden. The concern now is that, was the president potentially infectious when there was contact on the debate stage? So this doesn't change the fact that contacts of contacts are not necessarily quarantined. They don't have the same risk. But because we don't have all of the contact tracing, we don't understand all of the dynamics here, there's a reasonable question to ask about who needs to be involved in quarantine and contact tracing.
Yeah, and I think, Vice President Biden may or may not be now a contact of a known case, depending on how you want to define contact. How close were they in that setting? Obviously, we know there was a time that they were close together, but were they 12 feet apart? And that will all be vetted. I'm sure the vice president will be checked on a daily basis, but he now becomes a contact of a known case. So,
but we have to be careful, because if in fact Trump was negative the day of the debate and negative the day after the debate, technically Biden isn't a contact.
Probably.
So we just have to say he was positive later, and so if those 2 points, if those 2 statements I said are true, if he was negative before the debate and negative the day after the debate, technically Biden was not a contact. But now, if he interacted with someone else from the president's party or anybody else out there who was positive, then he could be a contact. But unfortunately, this story will take about 2 weeks to fully unfold.
yeah.
And then one last, we're getting a lot of questions, but one last that's directly related is Martha wants to know if the president is quarantined for the next 14 days and he feels better, would he be ready to go for the next debate?
Yeah, I think that's us speculating. We're way out of our lane on that one. So we'll probably just say, this is my last comment is still true. It will take 2 weeks for us to really see how this unfolds. And, we're an impatient breed, or we're an impatient lot, and we want to know what the answers are right away. But the reality is we don't know what all the answers are. Dr. Fauci has been criticized for being wrong about things around this virus. But why are we surprised? If we knew all the answers, it wouldn't be new, right? The point is that, based upon our best of our experience and what we know, people have tried to predict what's going to happen around this virus, and we were wrong because we didn't know all the answers, because it's new. And now that we've learned more, we can still be wrong because it's still new. And that's why they call it the novel coronavirus. And I think what we just have to do is hope that, and believe in what we know, and believe in medicine as best we can here, that there are some effective therapies that we didn't have 6 months ago, that most people who are of an older age and maybe have other comorbid concerns still do okay. And that we're going to hope that the president and the first lady and all who works in his party and Vice President Biden and others are all going to be okay. Because that's really what we want to have as an outcome for this. So.
And Janet has a question that might lead us back to what our topic was today. She wants to know, what is the age range of our patients that are in the ICU?
Yeah. Do you?
Certainly, I don't know exactly offhand today, but last week we did have an age range of 30 to 92 or 95, I believe.
So we got to 96 last week.
96.
Yeah.
So there is a large age range there. The same thing on the floors as well, early 30s to your early 90s as well. So both ICU and on the floor. And again, that was last week.
And I think today there's an 18 or 19-year-old here in the hospital.
Yeah.
So.
Yep, I think that is consistent, right? We've said this before, but in general, we are seeing more younger, healthier patients in the hospital. And I'm not sure.
Yeah, let's segue right into your.
Yeah, I'd say there we go. I think we have slides here. So this is looking at hospitalizations, and this is just a comparison. This is by no means a comprehensive look at statistics, but I did think it was important to sort of share this picture. So since March 1st, since the beginning of the pandemic, we have had 773 unique patients that have generated 826 hospitalizations, meaning that some of those patients have been hospitalized more than once. But it's a small number. If we just look at the number of hospitalizations that happened in March and April, the first 60 days of the pandemic, there were 153, or 18.5% of that 826 hospitalizations. If we look at August and September, 60 days, 338 admissions, or 41%. So in one 60-day period, we've had nearly 41% of the total admissions to the hospital, which I think should reinforce to us that we are seeing more hospitalizations. Even if the census number that we share with you daily has been plateauing or fluctuating in the 20s or 30s, more people are coming to the hospital. The next line shows that they're staying a shorter time. The average length of stay in March and April, over 10 days in the hospital. The average length of stay in August and September, just under 6. So we're moving more people through. And the average age is slightly lower for those that are being hospitalized. The bottom line here, and I have in quotes healthy, this is a reminder to me to define what I mean by that, but we track whether the patients that are admitted to the hospital have chronic medical conditions, any chronic medical condition at the time of their admission. And so when I say, quote, healthy here, I mean no chronic conditions. These patients have none. They're not treated for any chronic medical disease. We don't find any during their admission that says, well, they actually had hypertension but didn't know it. These are truly people with no chronic medical conditions. In March and April, that made up 5.5% roughly of our admissions. In August and September, it was 17%. So nearly 1 in 5 that's in the hospital in the last 60 days have no medical problems. And that's a pretty significant difference. And so that overall picture, I think, just reinforces this message we've said. More hospitalizations, younger patients, healthier patients, and shorter time in the hospital. The next slide is just a similar look at deaths. And this one is a little harder because it requires some qualification. So the number of deaths in March and April, we had 21, are 31, almost 32% of our total 66 deaths. In positive, COVID-positive patients. In August and September, we had 11 deaths. But deaths do, remember, follow hospitalization by days to weeks. And so the larger number of hospitalizations, we'll see the impact in deaths from those hospitalizations later on. So what we're really seeing here is maybe July and August hospitalization numbers resulting in death, which is a slightly lower number than, say, September. Nonetheless, it is a good look that those who end up not surviving their hospital stay are staying longer than those who do well and go home. And the average age is still in the 70s for those that don't survive a hospital stay. So I think that does paint a picture that while more younger patients are being hospitalized, a good percentage of them are going home, and really those that are severely ill and don't survive are a little bit older, and none of those deaths in either of those time periods were in that healthy, right, no chronic medical condition bucket.
All right. So those are really important points, and appreciate the insight and the honesty about that. We've got some questions that we've pulled in from the audience over the last few days, and so there's another question first rolling in, Jill.
Well, yeah, Anil, you may remember Anil.
Of course, Anil
he's watching
Gallmarker.
today, and he
Hi,
had
Anil.
a question.
Hi.
He
Neil
said,
Gallmarker was a patient, and he's been on our program a couple of times and was hospitalized here. So
right,
Neil.
a couple of, like 3 times, I think
Yeah.
he's been back.
He's been great.
We call him a frequent flyer or a long hauler.
Yeah, long.
He says, I have to retest before each visit to the OR. Are there any documented reinfections as of yet?
Okay, that is a great question, Dana.
questions.
Yeah, there are some we know about.
Yeah, this is one of the few topics that I think about on a daily basis, because we know that there are published cases of reinfection. Those are very good studies looking at the exact virus isolates from those patients. I believe the first one from Hong Kong was 142 days from their original infection. I don't know about the Nevada case, however. In one of those cases, one person was asymptomatic. In the other case, they actually had more symptoms than the first time. That is something we are working to address here at the health system. It's going to be very difficult. Obviously, as I mentioned, the isolates have been tested. Their genome sequence has been done, so they could really very well document reinfection. But that is something moving forward. The other issue, again, our main priority is patient safety, and we know that if you undergo a procedure and you have COVID in that peri-procedural time frame, you have a higher risk of complications if you are positive for COVID. To answer your question very well, we don't have a good answer right now about how are we going about identifying if you've had reinfection or not. So our main goal is to really identify if you have COVID, because we don't want to put you at higher risk with whatever procedure you're getting if you do have either new infection or possible reinfection.
Well, and I think that's the answer. You're going to keep getting tested because we don't know the truth about this, David. And so our policy has been that you're going to get tested for any procedure here prior to the procedure, whether you've had COVID or not.
Correct. And I think, we know that at least there's the possibility that some perioperative or periprocedural patient could be reinfected. We've not yet seen it in our patient population. But if we pivot from that to the value of that screening testing for those coming to the OR, we're just under 300 patients as of yesterday. Maybe today we're at 300, but 300 patients who had no symptoms, who didn't know they were positive, coming for a surgery or a procedure that tested positive. And so we're finding people and we're helping manage the spread of disease and make sure that the outcomes of those individuals are not compromised because they're positive and didn't know it. The same is sort of true on the screening testing that we're doing for admissions. So it's a little less, maybe 270, 250, I can't remember off the top of my head exactly, but in that range, patients who have been found to be positive who had no symptoms at the time of admission to the hospital. So that screening testing, regardless of whether you've had the infection before, had the virus or not, remains an important part of keeping our patients safe.
Exactly. And those are really important points.
And I think if that happens, we would identify and go through that on an individual case-by-case time. So.
And to say to Anil, hope you're getting better. I hope you're still
Yes.
recovering, and Godspeed to you. You're a great person. We so appreciate your questions and appreciate all you've done for our system as we try to spread the story about coronavirus.
Okay, we don't hear much about nursing homes and prisons lately. Are they allowing visitors? What is the virus spread?
Yeah, great questions. And I think that there have, the nursing homes were really closed down to visitors. They've been slowly reopening on a very limited basis and in very special circumstances. I know that for a fact that it's still in nursing homes. We've been contacted by a few even recently. So talk to us a little bit about that, David. Where are we with that?
Yeah, so the important parts of this conversation, I think, are, we've talked about sort of the local transmission dynamics in a community being really important to what's happening in the long-term care facilities or the hospitals or other healthcare facilities in that area. So here are the two stories I'll tell you about that. We know from a number of our contacts across the state of Kansas that we are seeing, especially in the non-metropolitan areas, so not Kansas City, not Wichita, an increase in the number of outbreaks. So they're smaller, of course, in a smaller population, but an increase in the number of outbreaks in long-term care facilities. So it's definitely not gone. We also know, for example, we had a call last week. We meet regularly, try to do it weekly or a couple of times a week with the other chief medical officers from across the metro. And we learned that all but one of the Missouri veterans' homes, so the VA long-term care facilities, had outbreaks of patients and employees. And what it appears, or what appears to be the case in this picture, whether it be the non-metropolitan counties in Kansas or even these veterans' homes, is that it's employees, it's the healthcare workers bringing the disease in from community spread. And so the sort of federal government has put in a practice of testing every employee who works in a long-term care facility on a regular basis, sometimes even once a week or twice a week, depending on the transmission in that area, to help prevent this from becoming a bigger problem, because those are the patients that are more likely to die, right? The patients who would be living in a long-term care facility who are elderly with more chronic conditions. So we want to do everything we can to prevent the spread there, but we're definitely still seeing that picture. It's just different maybe, and we understand it differently, and we're managing it differently than March or April.
All right. This is an interesting question, though, because I think it also moves to this the value of masking, which is kind of what the next question's around.
Right,
Jill.
and to add to that, we have people today like Stacy who says, if masking works, why is the virus still spreading? So let's look at this next question, and you can wrap it all together.
I'll do that.
The
Yeah.
journal Lancet recently concluded that 172 investigational studies show wearing face masks reduces the risk of coronavirus. But does that have any value if not a double-blind, scientific study.
Yeah, we'll take all that on. So the first comment question, I think, is if masking works, why does the virus still spread? And the answer is the masking works, but it doesn't work if it's not on your face. And we see people out there frequently who don't have a mask on and are often close together. Now, I walk around in Brookside and places like that, and you see the bars, et cetera, and people sitting close together in restaurants, which have been identified as kind of this mini hotspot in general. And people don't have their masks on. And so guess what? You're at risk. I mean, this is not a surprise. We've been saying this for a long time. So masking does work. We've known that it's worked for years and years and years. It's not new news. It's why we wear masks in the operating room all the time. It's why it's worked in the hospital. Remember, we keep coming back to this story. It's not a perfect story, but we don't see these terrible outbreaks coming from our hospital units where we congregate our COVID-19 patients. And why is that? The answer is because we wear masks, we try to wash our hands, we do maintain social distancing as much as possible, but our caregivers who are at the bedside for our patients are wearing surgical masks. If there's an aerosol generating procedure, that is when there's a lot of potential viral cloud, then they're going to wear an N95 mask. But we don't see a lot of spread in those wards. And why is it? Because masks work. Dana, fine, this is not a double-blind study. It's hard to blind whether you have a mask on or not. But the reality is, I don't need this study to show that the masking works.
Yeah, I think that's a good point. It's a very good question. It's a very
it's an insightful question. Yeah, it's a great
Absolutely.
question.
We have talked about the need for double-blind studies, especially when you're looking at therapeutics, drugs that we're using against coronavirus. These are non-pharmaceutical therapeutics or interventions. I think it's a very good question. We also understand that it's not masking alone, but it's other issues that we're dealing with, the distancing, the hand washing, all of these non-pharmaceutical interventions. I think it would be very hard to develop a double-blind study of just masking itself. So setting up a study like that is going to be very difficult because you have these other interventions that are taking place. But it's a very good question. A lot of these studies are observational, looking at time periods prior to shutdowns and mask mandates, to other just individual investigations looking at spread, maybe at super spreading events when people, say, on public transit or in gatherings are infected, but maybe people who are more distancing and wearing masks were not infected. So it's a very good question.
Well, but the reality is that, the simple reality is, you don't do a double-blind thing for everything in medicine because you can't.
Right.
So let's talk about hip replacement. Does hip replacement work? We've never done a double-blind study on it because, you can't. You just can't. And so, but we know that hip replacement does work. We know what the complications are and the risks are, but the reality is hip replacements work. David, masking works.
Yeah, I think the point that it's impossible to do a double-blind study for this, right? If we said the study volunteer, the subject, the person that was wearing a mask or not wearing the mask is going to know if you wore a mask or didn't wear a mask.
Plus, who wants to go be the guy? I don't want to volunteer for the non-mask wearing.
We would never be double-blinded because the study participant and the investigator would know if you had a mask on or not. It's impossible not to know.
Yeah.
And so, the absence of double-blinded, placebo-controlled, truly rigorous studies when we cannot do them doesn't mean that there's not evidence that a mask works.
Yeah, I don't need hip replacement works. I don't need a double-blind study. I'm not going to do a fake hip in somebody. Wait a minute, that doesn't make any sense. So does not masking. Okay.
How effective are neoprene masks and gaiters if there are 2 layers?
Okay, let's go. Who wants to grab that one?
I'll start by saying we need to get back to the initial reason we were advocating for masking in the community, not in the healthcare setting, but in the community. And that means neoprene masks, cotton masks, and even surgical masks, if you can get them. It is for barrier protection to other people in case you have the disease and don't know it. So it's very hard to say. I don't know that we know one for one. Obviously, there have been some scientific laboratory studies that look at droplet dispersal with different masks on. I think if you can have 2 or 3 layers of the gaiter, if you can have a neoprene mask, those masks are pretty thick. I think they can provide barrier protection. And can they provide the wearer protection from infection as well? Possibly. We know that there are signals and different studies about that, a little bit of data. So I think that they could both work. And we want to really make sure that the mask is for a barrier in case you have the disease. And that is why just wearing a face shield or eye goggles without a mask is really not considered barrier protection because you have nothing covering your mouth and your nose.
Not much more to add. I think, to Dana's point, we probably can't provide comparative evidence to say a double layer gaiter is 70% as effective as a surgical mask. We don't know that. I'm not sure we ever will. But the things that we do know and the reasons that we use any sort of mask as a barrier device should reduce your risk and would be helpful. It's probably true that some are better than others. We just won't be able to say with certainty which one you should or shouldn't do.
Okay.
My husband believes COVID-19 spreads only in large groups, and he can talk to another person 6 feet apart and no mask. Is that safe?
It's about relative risk, right? You're better off if you wear a mask. 6 feet apart is going to be a little more helpful to you. It's going to get cold really soon. Actually, I kind of did this last night. You saw us go down in the freezer before and take deep breaths, and you can see where our breath clot goes. In the next couple of weeks, you'll be able to do that on yourself in the morning. Go outside and just take a breath and realize when you breathe out, that's where your breath clot goes. That's where the virus is going. So a lot of it depends upon what you're doing when you're 6 feet away. If you're shouting at each other, you're probably not far enough. If you're exercising, you're probably not far enough. If you're having a calm, simple conversation in a reasonable voice, you may well be, especially if the wind's blowing if you're outside. But it's all about relative risk. The more you do, the further apart you are, or if you have a mask, the safer you are. I think that's really what we've been trying to preach the entire time. This is about trying to stay safe. And how hard is it really to wear a mask? So if you go outside and you're 6 feet or more apart, do you have to have a mask on? Yeah, probably not. But if you're going to shout, if you're going to scream, if you're going to get a little more active, you're going to get a little closer, should you have a mask on? Yeah, probably so. Team?
Yeah, and I think this goes back to our last question. I would certainly prefer both parties to have a neoprene or a 2 or 3 level layer gaiter on. Talking 6 feet, 8 feet, 10 feet apart, you are going to reduce your relative risk, and that's the important thing here for sure. I think we know from mouse studies that really it takes a very low amount of virus, so about 200 infectious particles, to really cause an infection. So if you are closer and no mask, that's going to be higher risk than if you're further apart and both parties are masked.
Okay.
Will a vaccine protect me if I take it and others around me don't?
So what do you guys think? I think vaccines can be protective to you because they can help you already mount an antibody response, and even if somebody else doesn't take it, it should help you still.
Well, I think that the question in general, can a vaccine protect me if others around me don't take it? The answer is yes, of course. We've known that for other vaccines for years, so a general answer would be yes. Since we don't have an approved specific vaccine in this case, it's hard to help quantify or even qualify what that protection might be. But I think if those around you aren't getting it, you shouldn't decide I won't get it because of that, because there will still be some degree of benefit to you and, actually, in all honesty, to those around you.
Right. It could be a significant degree of benefit, as we know with the flu shot. You get the flu shot not because of everybody else trying, but because you're trying to protect yourself. This is really not a lot different than that, which kind of segues to our next question, Jill.
When should I get a flu shot, and why should I get a flu shot when there's COVID-19 to worry about?
Wow, Dana. I think that this is a great question. This makes it more likely you want to get a flu shot.
That's exactly right. You want to get a flu shot more now because there's COVID-19. We don't have a lot of experience with COVID-19 and other respiratory viral infections or co-infection, including flu, because the influenza season was ending kind of when the COVID pandemic was starting here in the United States. But I think as we move further into it in the United States now, in this experience, in this flu season, we could see more co-infections. Hopefully we'll be like Australia and didn't have a lot of influenza activity. But you never know, because then you have 2 insults or 2 infections that your body is dealing with, both of which affect really the same organ, the lung, and that can lead to a lot of devastation and problem.
Yeah, and I'll take the bigger picture sort of look. We're going to have COVID infections impacting hospitals throughout this influenza season, throughout the fall and the winter. And that's something we've never had to deal with before. And historically, we've been taxed as a healthcare system in the wintertime in some years when they've been bad influenza years, with a number of people needing to be hospitalized for influenza. And the reality is, at the population level, if we look across our community, if we have lots of COVID patients and lots of influenza patients needing hospitalization at the same time, there will be an impact on the delivery system, on our ability to provide health care. So we want to prevent that. So get your flu shot. wear your mask, do all the things we're talking about here. We don't want a bad flu season. We just don't.
Yeah. And I mean, me, as a clinician up seeing these patients, my real concern, especially with influenza, is the secondary bacterial infections from staph and strep that can occur fairly frequently with influenza activity. So if you have COVID-19 and you have influenza, and then with influenza you get a secondary bacterial pneumonia as well on an organ, your lung, that is already damaged, it's going to be very hard to recover from that as well. And that's my concern clinically on a daily basis.
And when do we get the flu shot?
When you want to get it. I think
Yeah.
we're probably getting to that point now,
Yep.
Dana, that any time.
Yep.
Initially we said don't get it too early unless you want to get 2 flu shots.
Yeah.
But at this point I think we can say, let's just go get one.
I think from here on out, I think you're good to get one. Try to get it before November, but any time within this month I think is going to be healthy.
Why do I have to quarantine for 14 days? If most people are exposed on or before 10 days, where did the number 14 come from?
Okay.
So
Wild.
I think that question is saying most people who are exposed test positive on or before 10 days, and that is true. That's probably 80 or 85% maybe of those who are exposed and that are going to test positive will test positive by day 10. The 14-day number, though, is really simple. It's the observed incubation period. So we have plenty of cases, really across the globe, where patients have converted, started to test positive at day 11, 12, 13, or 14. Not too many after that, very few actually. Yeah. So we know that that 14-day window is based in science, and it is true that the majority are likely to start to test positive between day 5 and 10, probably, 5 and 11. Yeah. But not everyone. And so our answer is, because we're interested in preventing spread across the community and preventing transmission, that 14-day window that is synonymous with the incubation period remains the period of time that we need to quarantine.
Yeah, and we've seen an employee symptomatic at day 12 after exposure, so I think
It can happen later, and
Yep.
that's where we have 14 days.
Yes.
And it's really about trying to keep everybody around you safe, right? That's the goal. Keep the folks safe.
And before we get to our very last question, a reporter has a question about your slides. They said, are the percentages of total patients in the health system of the hospital slide?
Total percentage.
These are
Yeah.
hospitals. So this is our hospital, not
Right. This
our
is not
system.
Hayes or other place, St. Francis. This is our hospital.
Hospital. Okay. And then the other question was, how soon after I've had COVID should you get a flu shot? Do you have to wait? Do we know?
Yeah, that's very good. There is a little bit of CDC guidance on this. Typically, if you don't have fever and are otherwise feeling well with other respiratory viral infections, you can get the influenza vaccine. The same is true for here. However, we don't want you to be out spreading the disease if you are ill. So typically, if you have COVID-19, you need to wait for that 10 days after your isolation period is over. And that is the latest guidance from the CDC on when to get influenza vaccine if you have COVID infection. If you're otherwise okay and you have a little bit of sniffles, you could probably get influenza vaccine if you have COVID. But if you do have COVID-19, you have to be isolated at home for that 10 days. Anyways, we don't want you out in public or coming to the clinics or pharmacies, wherever you may get your influenza vaccine, and spreading it there. So it's really waiting for that 10-day period after your isolation ends.
All right.
Last question for today. Is it safe to visit apple orchards and pumpkin patches with the high rate of community COVID-19 spread?
And I think, this is the same answer we would give, not even just about pumpkin patches and apple orchards. It's about anything you want to go out and do. And the same things are true. If you wear a mask and you can stay socially distanced, it's going to be safer. If it's not, it'll be less safe. The reality is the most safe place is probably still your house. But you can go outside, and I think if you can maintain the social distancing, and if people around you are wearing a mask and you're wearing a mask, I think you can stay pretty safe, and I would feel comfortable with going to a pumpkin patch or to an apple orchard. And the idea of fresh Jonathan apples always makes me want to go to an apple orchard. So I think you can stay safe in that environment. So,
Yeah.
Hey team, coming up on Monday we have another great program. Chancellor Dr. Doug Girard will be back here. He's Chancellor of the University of Kansas. We'll be talking about how things are going. Actually, a great article this morning in the New York Times about how different colleges are handling it and how some places have stayed really safe. I'll just say, I think KU's done a really good job. Chris Wilson is our VP of System Innovation and Integration. He's worked really hard with the Lawrence campus to try and put together a plan, and both of these guys are part of that plan. And part of our pandemic response team to try and keep the students in the community of Lawrence safe, because the KU's our partner, so we want to make sure that they do. We got some great masking pictures out there. It is Red Friday, and there's reason to celebrate. Indeed, there is. I don't know if Fauci's a Chiefs fan, but we're going to say so today. We want to keep everybody safe. So let's help keep Patrick Mahomes safe. Wear a mask. That's also true for our entire defense. Let's just say that. We want to wear a mask to protect our family, keep school and businesses open. Doesn't get any cuter than when a 2-year-old says, "Hey, I got to have my mask on." So we also want to remind you to think about how you could incorporate a mask into your Halloween costume. If you intend to do that, we'd love to see you have a picture, and you can send that to us because we'd love to see you with the Halloween mask that includes a mask to keep everybody safe from the coronavirus. Wow, this has been a big day, guys. Final thoughts, David?
Well, yeah, I think a lot going on. That remains to be remains a pattern that I think we've all been dealing with since March. I was thinking as you shared the pictures yesterday, I took my youngest, so 3.5, was his 6-month visit to the dentist, and it had been delayed and delayed because of all of this. And we walked into the pediatric dentist, and he had his mask on, and everyone said, "Oh, wow, isn't that cute?" And he was really good about navigating the whole process. And I think that is just a reminder that we use masks and physical distancing as sort of the intervention that prevents us from needing to lock down and stay home all the time. And that means really every place you can, everywhere you can. And the reason I bring that up is I just read, and the study isn't maybe all the way complete yet, but the observational study out of India that showed that when you're not wearing a mask, that kids of all ages are just as likely to be infected and just as likely to transmit, and they've got a really big population. And while the dynamics may be a little bit different than here, I think that applies. And so, even when you're taking your 3-year-old to the dentist, or putting a Halloween costume on, or going to the apple orchard, anytime you can do those things, wear a mask, stay apart from people you don't live with.
Yeah, it's the same message. We know that cases are going up. Hospitalizations will follow that by a couple weeks. Hopefully no deaths, but deaths will follow that after a couple more weeks. So continue to do those things. We know, and we have seen now, that the virus can infect even the people that, in the highest echelons of government. And we've seen this. So continue to wear the mask, distance, don't meet in large groups. I know that there's going to be college football and the Chiefs this weekend. Meet in small groups, do it outside if you can. Keep yourself safe and your loved ones safe as well.
We had that photo a moment ago about help keep Mahomes safe, wear a mask. That came from Pam, who had this photo of her daughter who lives in Montana with her husbands. They came by this naturally. They're in Montana, so they're part of our program, I think. And he graduated from Texas Tech. They're pretty big Patrick Mahomes fans. We all are. Most of all, we're fans of trying to keep each other healthy and safe, right? And do I worry? Yeah, sometimes I do worry. I worry about you if you're not doing the things we need to do. I want to say a special thank you. This has been a big program today, to Jill, to Logan, to Anthony, to our interpreter, to everybody who's been a part of this, and of course to David and to Hawkeye. Our message is the same every day. We try to help you stay safe. We're not going to do it by flapjacking. We're going to do it by just trying in a very calm, measured way tell you the truth. Remember, coronavirus is not a superhero, but really neither are you or I. We can stay safe, but we have to follow the pillars of infection control, the ones that this guy, Chiefs fan or not, talks about. Because the reality is they work. They've worked for every epidemic we've seen. This is not new news. But it is news when people contract the virus, and people who are close to you, and people who you care about, and our leaders do. The reality is, though, we can all stay connected and we can all stay safe. We just have to follow those pillars. And if we do that, we're going to be okay. Today is probably a reminder, though, that when we first started this show, we would always say at the conclusion, like the Wizard of Oz and in Kansas, there's still no place like home. And you know what? That's still the truth. As we head into the cold and flu season and things get harder, just remember, there's still no place like home. We'll see you on Monday. Stay safe out there.